It's my pleasure to lecture about a prenatal approach of bilateral echogenic kinase because it's a lecture that I love very much. In fact, it's a real challenge in fetal medicine. And when I was a fellow in St. Justin, echogenic kinase, when it's bilateral, was equivalent to polycystic disease and the ADPKD form. But it's not. And when you are dealing with some bilateral echogenic kinase, you should do a complete fetal sonographic analysis looking for associated morphological anomalies involving the extremities, also the posterior fossa, the thorax and spine, and the bone, in generally speaking, and the fetal biometry, because you have to look for macrosomia, but also for IUGR, and we'll speak about that later. The family history is so important, and in that case, the sonographic renal examination of both parents is mandatory. And after that, it will be a multidisciplinary approach with fetal medicine specialists, genetician, nephrologist, and urologist. And the biologic workup is also important with development of gene panel testing. So first of all, analysis of the renal parenchyma. You have to know the size. It can be large kinase, it can be small kinase, it can be kinase normal for the age. You have to look at the cortical medullary differentiation. That means that it can be all echogenic, but the echogenicity can be on the medulla or in the cortex. Look at these different cases here. You see it's globally echogenic. This is in the medulla, and this is more in the cortex. And in fact, it's important to differentiate this kind of echogenicities. Is there some cyst or not? The size, number, localization. Is it in cortex, medulla, cortex and medulla? And for that, it can be interesting to use high-frequency probe to have a better analysis of this cyst. Well, how is the colic system? Is dilated or not? How is the bladder? Is there any keyhole sign or not? And how is the amniotic fluid? So first of all, when we are dealing with bilateral echogenic kinase, we will focus on second and third trimester, because in the first trimester, as you know, it's a normal variant because it's related to physiological echogenicity of the interstitial tissue, which decreases with nephrogenesis. So we are dealing with this kind of echogenic kinase, and we will speak about nephrologic disease. So urologic obstruction causes should be ruled out, either bilateral, upper tract, or low urinary tract obstruction. Sometimes it's not very simple, as in this case, you see these patients at 20 weeks, and you see it's globally echogenic, no corticomedullary differentiation, and as there is no visible cyst, there is bilateral pelvic dilatation and an empty bladder. Nothing else when you scan all the baby, and no familial history. What is this? In fact, there was a pathological examination because the parents asked for termination, and there is diffuse cortical microcyst in the medullary. Cortical microcyst and dysplasia of the medullary. These cortical microcysts are, when it's at the external part of the kidney, are most of the time related to obstruction, and it was a fibrous and inflammatory disease of the UPG. So sometimes it can be difficult, and in that case, it was. So we are dealing with, in fact, some bilateral echogenic kinase related to nephrological diseases. So the first one, it's polycystic kidney disease. It can be the ERPKD form or the ADPKD form. If we are speaking about the most common or the most known echogenic kinase, it's the ERPKD related to a mutation on PKD1 gene on chromosome 6, and it gives rise to a fusiform cystic dilatation of the collecting duct. In fact, it's mainly in the medulla, but it extends towards the cortex. But the outer cortex is spared. The main presentation is the very huge kidneys detected in the second trimester with no corticomedullary, so no CMD, and a decreased amount of amniotic fluid. And in that case, when you suspect this kind of disease, you should use the high-frequency probe because you may see the dilatation of the colic tubes in a radiated pattern. This is echogenic kinase. You are 24. The length is almost 40. There is no amniotic fluid. There is no CMD here. And if you use the linear probe, you will see this. This is the cystic dilatation of the colic tube. And in that case, you have the perfect correlation with the pathological specimen. So this is the first presentation, the most common presentation. You have a less frequent presentation with kidneys less enlarged with a reversed CMD. Reverse, that means there is interfaces increase in the medulla with a normal amniotic fluid with a better prognosis. This is not a very frequent presentation. You see here the echogenicity is in the medulla. And this is a special form of ADPKD. So let's move to the ADPKD. You know that it's more frequent. There is 3 genes. De novo mutation in 10%. That means if you look at the kinase of parents, you will find 6 cysts in 90% of the case. The cysts may be small or large, developed in the medulla and the cortex, and they are typically identified in the early adulthood with a progressive enlargement. Cysts may be present in liver, spleen, and pancreas, and in prenatal, the most suggestive presentation in over 80% of the cases, and seen in the second half of the pregnancy, it's a moderate enlarged kidneys with an increased CMD. That means that there is a hyperechoic cortex related to multiple small cortical cysts at this stage. You cannot see the cyst, but you see the hyperechoicity of the cortex, and the medulla is hypoechoic. So you have an increased CMD. So this is this kind of patient. This is the mother, so you are sure that the mother have a ADPKD, which is known. And when you look at the kinase, you find that your system very good this day because you see the CMD very pronounced. And if you continue during the pregnancy, it will be more pronounced like that. And this is the typical form of ADPKD. There is another form, which is the rare pseudo-ARPKD form. It's the glomerulocystic variant. In that case, it looks like an ARPKD with a markedly enlarged kinase, no CMD, diffusely echogenic, but the prognosis remains favorable unless oligoamnios develops. Maybe there is some kind of kinase which look almost normal, but this is not known. Let's move to another pathology. Look at this kinase. They are echogenic, more in the cortex. You see that there is a cyst here. But there is IUGR, there is a suspect cardiopathy, and the corpuscle look very, very thin. And in that case, it was a trisomy 13. That means that each case you have echogenic kinase, you should do a karyotype to rule out any trisomy or other karyotype anomalies. Now, look at this kinase. They look completely echogenic. But if you do your whole screening, you see that when you look at the epiphysis, there is calcification of the epiphysis here and here. So you are dealing with a chondrodysplasia punctata. So you have this, but you have also this. Look, there is a diffuse polymicrogyria. What is the diagnosis? We are a few, dog. You can say something. Okay, this is very specific for a peroxisomal disorder. It's a Zellweger syndrome. Okay, and in fact, we written this article about the antenatal manifestation of this metabolic disease. There are plenty of diseases like that, and in fact, we have divided this chapter into echogenic kinase, some echogenic colon, and on the echogenic kinase, you will find, in fact, the peroxisomal disorders, and there is also disorder multi-esal, dehydrogenase deficiency, some very rare disease. So let's move to another type of lesion here, very echogenic, some cyst here, and look at the biometry. Very huge baby, macrosomia, and in fact, when you look at the alpha fetal, it's elevated, and the CGH show a large duplication involving one gene involved in Beckwith-Winman syndrome. And so we are in the case of macrosomia, a syndromic macrosomia, with the classic appearance of a Beckwith-Winman, or this one. So this is, in fact, very simple. Another findings close to the kidney that you can find, this patient was referred to us for echogenic kinase, yes, but also look at the adrenals. The adrenals are enlarged, and there is some cyst in the adrenal. You know what this? It's a very specific finding for Beckwith-Winman. Because in Beckwith-Winman, you may have bilateral hemorrhagic adrenal cyst, as in this case. So this is not very frequent. Beckwith-Winman is not very frequent, and Beckwith-Winman with this kind of presentation is not very frequent. But if you see this large adrenals, you are sure that you are dealing with a Beckwith-Winman. So let's move to macrosomia. So Beckwith-Winman, there is also Perlman, Golabi-Bedell syndrome. Let's move to other causes of echogenic kinase, ciliopathies. In that case, because you are dealing with autosomal recessive disease, the family history is important. Is there any exadactyly, meningocele, or osteodysplasia in the family, posterior fossa anomalies? And the first one is Bardet-Biedl. You know, there is mutation in more than 16 genes, and it's in fact characterized by post-axial exadactyly, progressive obesity, but it's the obesity after birth. This is very important because it's the diagnosis, the pigmented retinopathy, renal dysplasia, hypogonadism, and intellectual disability. And the retinopathy is the only constant findings. The diagnosis will be based on the familial history if you have index cases, but the main findings, it's exadactyly and echogenic kinase. But all this will be found in all ciliopathies. So that means this is not specific for Bardet-Biedl. So when you do some stuff on the gene, there is very large gene, so the workup to do this in the prenatal is very difficult. But it's very difficult to get the information if you do not have your information in the family. If you do not know the gene, you will not do this workup in the prenatal period. So the renal presentation, most of the time, it's diffusely echogenic kinase with lack of CMD. In some cases, you may have some cyst in the medulla. For ciliopathies, most of the time, it's in the medulla. But we will speak about Michael Gruber. For Michael Gruber, it's in the medulla, it's very large. And the tract is normal, with abnormality field, which is normal. And important findings, sometime after birth, there is normalization of the echogenicity of the kidney, and the echogenicity becomes pathologic after 2 years. So if there is a transient normalization, don't say it's nothing. It's normal to have a normalization in the first month of life. So this is this kind of echogenic kinase here. You see it's bilateral, very echogenic. And if you look, there is too much fingers. and you have this kind of anomalies. Most of the time, it's post-axial anomalies, and the baby at birth. This is very easy because a history of Bardet-Biedl with too much cyst, but this form is very particular because most of the time it's echogenic and you have some cyst. Here you see it's a honeycomb appearance. This is more the form that we'll find in Meckel-Gruber syndrome. Because in Meckel-Gruber syndrome, which is also ciliopathies, you have a post-axial axial dactyly, some CNS anomalies with occipital defect, and the kidneys are more enlarged with medullary cystic dysplasia. And it's very early, and this cystic medullary dysplasia is more extensive and developed earlier in Meckel-Gruber. And it gives rise to an enlarged and hypoacute medulla with a too pronounced CMD. And this is with often oligomyos. You see, it's like a honeycomb appearance of the kidneys. So maybe in some case it's not hyperechogenic, it's more hypo than hyper. You see that, you are sure that you are dealing with Meckel-Gruber. So we cannot speak about ciliopathies without speaking about Joubert and Joubert-like. This is most common ciliopathies, and you know the molar tooth sign. So most of the time, the kidneys can be of normal size or enlarged, and sometimes very enlarged. Most of the time, there is lack of CMD, and there may be cysts at the junction between the cortex and the medulla. Like this kidneys, which are very enlarged in that case. And if you look at the brain, here and here, you see the thickening and the elongation of the cerebellar peduncles, which is typical of the molar tooth sign. Maybe you may not know that some osteochondrodysplasia, like Jeune or Ellis Van Creveld syndrome or campylomelic dysplasia, are true ciliopathies. And I will show you one ciliopathy which is not well known, but we encounter this case in our casuistic. It's a serpentine fibula related to Notch2 mutation. This is a case where there is a fibula bowing here. And it was the same thing on the forearm. And the echogity was increased, not very large in that case, as you can see. And this is, in fact, this serpentine fibula, which are related to Notch2 mutation, and it was proven in our case. So you are here now. Is it complete? There is many etiologies, but the main etiologies is not in the panel. Because what is the main etiologies? Which is nephrological disease. It was shown by a guy from Toulouse, a nephrologist, that 1/3 of echogenic kidneys are related to mutation of TCF2 mutation, which is which is responsible for HNF1 beta, which is in fact the hepatocyte nuclear growth factors 1b. It's the main cause of fetal bilateral echogenic kidneys, and the recommended terminology is to speak about HNF more than TCF2 mutation. And it regulates development and growth of various tissue, liver, kidneys, intestine, pancreas. It's responsible for maturity onset diabetes type 5, and it gives rise to not only renal cyst, but also various other renal anomalies and genital malformation, ranging from agenesis, hypoplasia, Horsefoot kidneys, cystic dysplasia. And there were several mutations which may lead to different phenotypes, and it can be point mutation or it can be microdeletion. And 50% of the patients have, in fact, an anterior genes deletion relating to a microdeletion on chromosome 7. And this chromosome, this deletion, contains more than 15 genes. And because of that, there is some contiguous gene which are responsible for epilepsy and psychomotor delay. The gene itself, it's not responsible for a poor cognitive outcome, but when it's a deletion because of the contiguity gene syndrome, you may have some cognitive problems. What is the presentation of TCF2 mutation or HNF1? It's a very variable renal pattern, ranging from small to large. You have all kind of echogenicity and size. Most of the time, there is CMD which is decreased, but it can be, in some cases, also increased, similar to ADPKD. There may be cortical cysts, so there may be urinary tract dilatation. Most of the time, amniotic fluid is normal, and there are rare progression to end-stage renal disease. There may be genital anomalies, more frequent in females than male, and you may have also pancreatic and biliary anomalies. And the pancreatic hyperplasia is very specific to this mutation, but you can also have colorectal cyst, and we have a recent case with colorectal cyst and TCF2 mutation with echogenic kinase. So the main presentation is this. You have here multiple cystic disease kinase here, so very echogenic cyst. In that case, you are 24, you expected hypertrophy of the other kidney. In that case, there is no hypertrophy at all, 23 millimeters, too echogenic, some cyst. Look at the kidney of the parents. Half case are de novo, but half case are related to mutation in the parents. And in that case, you see small kidneys with some cyst within it, and it was a TCF2 mutation. This is another case. Look, there is echogenicity, there is some cyst, and there is no other malformation in the boy, and the parents have some cyst in the kidney, is TCF2 mutation. But another typical aspect of this mutation is this. You see, you are not dealing with ADPKD, but you are dealing with increased differentiation between the cortex and the medulla. And this is in the case where both parents are normal ultrasound. You know that in 50% it's possible. But if you think about ADPKD, most of ADPKD, in 90%, it's inherited from the parents. So you may, when you see this, you are more confident with TCF2 mutation than ADPKD. So when facing increased CMD, think about ADPKD and TCF2 gene mutation and look at the kinase of the parents. So it's almost complete because you see all these etiologies. You may also have rare etiologies like nephrotic syndrome Finnish type or bilateral renal vein thrombosis or maternal-induced diseases. This is a case of a pregnancy discovered at 6 months, and the mother had hypertension. And because of that, she was treated by angiotensin II receptor blockers. And she came with very echogenic kinase, oligoamyos, and we replaced the medication by Loxane with a progressive normalization of the amniotic fluid, but no normalization of the kidney. And in that case, it was, in fact, a poor outcome for this baby. This is a case where you see it's very echogenic, but it's only on one echogenic and enlarged. So this is very typical for thrombosis of renal vein. In that case, you should look at the inferior vena cava. Sometimes the thrombus involve also the IVC, and it can involve also the bilateral, contralateral renal vein. And in that case, we would get 2 echogenic kinases. We were most of the time very large. So to conclude, as you see, when I was a fellow, echogenic kinase was ADPKD point. now you know that there is a lot of etiologies. You should look for the familial history, should look for the renal ultrasound of both parents, and sometimes it's detection of unknown familial diseases, karyotype or CGH, look for associated morphological anomalies, extremities, CNS anomalies, long bones, look for the biometric data with the case of macrosomia, the case of IUGR with trisomy 13, and it's always a multidisciplinary approach with now a major interest in the development of gene panel testing. And in our center, we have developed NGS, and the result is in 2 or 3 weeks. So when we are facing echogenic kinase at 22 or 20, we ask for this panel, and we have all this gene. And it's maybe interesting, because if you are dealing with Joubert syndrome, I can do something about Joubert syndrome, but you have many genes, more than now I think we are almost at 30 genes, and there is no good correlation between the phenotype and genotype. But for some gene, we know that if the gene, this gene is involved, the cognitive outcome will be better than other genes. So this is important because Joubert syndrome, 1/3 of patients have a normal IQ. So if you know the gene, and you know that this gene is associated with a good prognosis, or most likely good prognosis regarding the intellectual development, it could be very interesting to have the genes in the prenatal period to improve the prenatal counseling. Thank you for your attention.